Yeah, so I'm Scott Whynot. I'm one of the family doctors in town. I work at Muskoka Algonquin Healthcare as well, and NOSM faculty. Um, so today we're going to talk about osteoarthritis and what it is and what we can do about it. So first of all, what is osteoarthritis? So it's the most common form of arthritis. You've probably heard people talk about they have rheumatoid arthritis, psoriatic arthritis, maybe for that term. Gout is a form of arthritis. Usually when people say they have arthritis, they're talking about osteoarthritis. It's the most common form. It is when cartilage in your joints break down. That's the main cause of it. So as you can see on the left there, this is a knee. This is kind of the skeletal structure of your knee. On the left is healthy cartilage. It looks, very pink, smooth. It helps your joint glide. On the right side is when cartilage starts breaking down. Right, it's very rough and very patchy coverage. It causes pain, swelling, stiffness of the joint. Right, when the joint doesn't glide like it should when you have healthy cartilage. It also can lead to the development of bone spurs. So again, this is another knee, and you can see on the left there's a normal knee with some good healthy cartilage there. Meniscus is in between the knee. Meniscus is a soft tissue that forms a cushion for the knee. And on the right side, you have some cartilage breakdown, very patchy coverage of cartilage on the knee joint. And you have these developments of bone spurs, these little bony outgrowths along the joint there. And that happens because when there's damage to the bone or damage to the cartilage, your body responds by trying to build up more bone for protection, right? But what ends up happening is that you end up with these kind of irregular bone spurs that can cause pain, that can catch on tendons, cause injuries with the ligaments, that sort of thing. So how does this develop? Two main reasons. One is your family history. Osteoarthritis is at times genetic. It usually involves the genes that are associated with cartilage growth and cartilage formation. As you can understand, if you have some sort of reason why your body doesn't build up cartilage the way it should, maybe it's not as strong as it should be and it degrades a bit faster, that can pass down through family. So if you have a family history of people having arthritis develop at earlier ages, maybe there's a genetic component to it as well. And then the other reason is general wear and tear, which comes with time. So what kind of wear and tear? Well, repetitive movements. A lot of times people who maybe work in certain industries where they're doing the same thing over and over again and wearing at their joint, that would tear it down. Aging, only because the longer you're around for, the more wear and tear, right? It kind of makes sense. The longer you've lived, the more use you put in your joints, the more wear and tear there is. Injuries. So a lot of athletes, especially, like soccer players, knee injuries are very common. If you have injuries to your knee when you're younger, maybe it changes the way your biomechanics are, you're walking, maybe it damages some of the cartilage. You're more likely to develop arthritis at a younger age. Weight as well. Higher weight means more wear and stress on your joints. So in general, the more weight you have, the more stress on your joints, the more likely you are to develop osteoarthritis. So where does osteoarthritis develop? Well, most common is the knee. That's why the first couple of pictures I showed you were the knee. By far the most common joint. As you can see, here's some x-rays that we have up here. On the right side is the healthy knee. This is an x-ray vision. You can see there's a nice kind of joint space between. That's where the cartilage and the meniscus would be. You don't see those soft tissues on x-rays. All you see is kind of a blank space. Whereas in the arthritic knee on the left side, you can tell that that joint space is gone. Basically, on the inside of the knee there's the bones are touching each other. That's because the cartilage is worn down, the soft tissues have worn down. Maybe you've heard the term bone-on-bone arthritis. That's what they're talking about there. When all the soft tissue's worn down and all you have left is your bone scraping on your bone. Symptoms of arthritis in the knee: you get pain. Obviously, your knees hurt. They feel stiff. This especially happens when you'll notice it walking, climbing stairs, especially with stairs. It puts more stress on your knee, obviously. you might find your knee gets swollen and you feel a bit unstable, right? As you can imagine, when the biomechanics are changed because of the wear structure of your knee, it maybe makes walking feel a little bit less stable than it did before. Hip is another very common area for arthritis, probably the second common compared to the knee. The picture there you can see on the right side is a normal looking hip, right? The ball of the hip joint goes into the pelvis, and there's cartilage there as well. And on the left side you can see the wear and tear of the cartilage like we saw on the knee. And then you can get bony spurs that form along the joint in the pelvis and in the ball of the hip socket as well. Oftentimes with arthritis of the hip, you feel pain that goes into your groin. Just the way the nerves are, the way the pain radiates, you tend to feel more pain in your groin. Pain with walking, bending, getting in and out of a car, people will notice because, to get in, you got to pull your hip up, puts more stress on the joint. That's when you tend to feel it. Another common place, maybe a little bit less common than hip and knee, but it's still very common in the hands. Base of the thumb is a very common place because there's a lot of movement, obviously, in your opposing thumbs. So more wear and tear on that joint, more likely to develop it there. The finger joints as well. As you can see in this picture, the last joint of each of the fingers, they're kind of swollen, they look bumpy. That's the signs of wear and tear on the joint, like those bony spurs that come up from arthritis. So not only will you have pain, but you might notice in your hands, you get some crooked fingers, some visible deformities, some bumps that grow along the joints. Spine is another very common place. This can be your neck, mid-back, low back. Neck and the low back are more common than the mid-back because they move more, right? You move your neck quite a bit, you move your low back quite a bit, bending, twisting. The issue with arthritis in this area, as you can tell, like the top, so this is kind of what your spine looks like with the vertebrae, this picture. The top part is a healthy looking spine. Yeah, your discs that go in between the bones, the vertebrae there, they're very nice, thick, healthy. And the yellow lines that are coming out, those are nerves that are coming from your spinal cord, which is inside the bone, protected by the bones. And you can see the holes where those nerves come out of are very wide and big, allowing for the nerves to flow through easily without being compressed at all. More towards the bottom of this picture, you can see the discs are shrunk. The vertebrae have some bone spurs, like it's more pointy at the bottom because of the loss of the supportive structure. And the exits where the nerves are coming out from the spinal cord, there's not much room there. So oftentimes those nerves will get pinched, especially with certain movements. You might get pain that radiates down your legs. In your neck, might get pain that goes down your arms to your shoulder because those nerves are chronically getting pinched and irritated coming out from the spinal cord. Another very common area, the shoulder. Again, healthy-looking shoulder on the left side, healthy-looking cartilage. And on the right side, there's the eroded cartilage that's all broken down. Shoulders, you might feel stiffness, especially with lifting, overhead activity. Anytime you're putting the joint at more pressure, doing with weight or reaching, things like that. And then another area that oftentimes people will develop arthritis is in your feet. It tends to be mostly in the big toe, kind of the knuckle of the big toe, the metatarsal phalangeal joints, what we call it. But that's the area that moves the most in your foot, right? Because your big toe is the most important area for balance and walking. So that's where you're going to develop arthritis because that's the place that's having more wear and tear. With this, you might get difficulty walking, feel stiff, that sort of thing. So osteoarthritis can happen in any joint. We've highlighted a few of the very common places that people complain about, but it can happen in any joint. And how do we treat it is the question, right? Very common condition, how do we treat it? The point of treatment is not to fix it because you can't fix wear and tear, right? There's no pill, there's no treatment you can take that makes the cartilage grow back, that puts the joint back to what it used to be like. So the goal of treatment for arthritis is to reduce pain, to improve joint function so that you can do more things with less pain, less stiffness, and to slow disease progression, to try to stop it from getting worse. And when we think about treatment for arthritis, there's 3 kind of main categories of treatment. The first is lifestyle changes. And in this, I've included kind of anything that you can do that's kind of non-medication. So we'll talk about a number of these things throughout the presentation. Medical intervention and then surgical intervention. We'll talk about each one of these things and what they can do to help with arthritis. So in terms of lifestyle changes, the first most important thing we recommend is exercise. And you might wonder, osteoarthritis is wear and tear. Isn't exercise just adding more wear and tear? And it potentially is if you're doing the wrong sorts of exercise. When we say exercise for arthritis, what we're thinking of is low impact activities. So I've highlighted here walking, swimming, cycling, something that's not putting a lot of high impact pressure on your joints, but allowing them to move and glide frequently and often, and to help develop the musculature to help to support the joint, to maintain good posture. So things that would be, a more high impact, maybe running, right, especially on hard surfaces. Not that you should never run, but if you do have arthritis and if you're running quite a bit, you're going to have a lot more pain with that, and it's likely going to make things worse. Strength training we recommend. Again, this is kind of low impact strength training to use muscle strength and muscles to help support the joints. We're not talking about trying to bench press 300 pounds or trying to deadlift as much as you can. More less weight, more repetitions, that sort of thing to help develop muscles. The main thing to think about with exercise is to balancing activity with rest to avoid overuse. You don't want to push your joints so far that you can't walk for the next 3 days, but maintaining activity and keeping the joint moving is important for the long-term pain relief. Weight management is another treatment that we recommend for osteoarthritis. The reason being, the more weight you have, the more stress that's going on your joints. And the way the biomechanics of your joints work, especially with the knees where osteoarthritis is most common, is losing even just 1 pound of weight reduces the pressure in your knees by 4 pounds, just because of where the stresses are going through. So we're not talking about losing 100 pounds, even losing 5 or 6 pounds if you are slightly overweight would help reduce a lot of pressure on your knees. And in fact, a study found that if you lost 10% of your body weight, it results in a 50% reduction of pain. 10% of your body weight's a lot, but just the general concept that even a little bit of weight loss helps a lot with pain. So you get a lot of results for even a little bit of improvement. Physical therapy. So physiotherapy and seeing a physiotherapist or athletic therapist, they can help give you personalized exercises to help with to strengthen your muscles and improve your joint stability. So this is when you see kind of a more specialist to help look at your own specific biomechanics. Maybe your quadriceps are weaker and it's putting excess strain on your knee when you're doing certain activities, or your hamstrings might need extra work. But they're seeing a specialized therapist can help design a specific treatment plan for you yourself, because everyone's a little bit different in terms of how their body works and where their arthritis is. And one of the main things that, in my opinion, that a physical therapist can help with is posture. We'll show this a little bit later, but the way you're moving and with your posture can really help reduce the stress you're putting on joints. And just like we saw with the knee pain, having proper posture, having proper biomechanics can significantly reduce the pressure going through your joints. Here's one example of posture here. On the left side, you can see the foot's kind of collapsed inwards a little bit, so the knee, there's more pressure going kind of on the inside of the knee when they're walking. So especially if you're developing arthritis on the inside of your knee and you're putting pressure on that area over and over, whenever you're doing any walking, whenever you're doing activity, the pain's just going to get worse. So if you work with a therapy team who can help identify these factors, help strengthen the muscles that need to be strengthened, realign your biomechanics, that's going to help with your overall symptoms and allow you to do more despite having osteoarthritis. And this is true. This is an example I wanted to show for the shoulder. If you have arthritis in your shoulder and and it hurts when you're doing overhead activity, you're reaching, lifting, pulling, that sort of thing. The person on the left here, when you're standing, with a straight back, shoulders back, put the joint at a good biomechanical position. That's going to allow you to put the joint through its full range of motion with less pain. Less grinding if you have some bone spurs, less grinding if you have damage in your cartilage, versus, poor posture when your shoulders rolled forward and already at a biomechanical disadvantage, and then you're asking your shoulder to work more, and that it's going to be grinding on the bone spurs and on the cartilage, and you're not going to be able to do as much. So someone like a therapist can help identify these things, help strengthen maybe your back, your posterior shoulder muscles, put yourself at a better position so that you can improve your activity with less pain. This is kind of a complicated picture, but just to reinforce the concept that depending on your posture, you can put a lot more stress through certain joints or your back the way you're lifting. Like when you're lifting with your knees bent and your back straight, it puts a lot less pounds of force through your low back than it does when you're bending at the back and then pulling it back. So, someone who has arthritis in your low back, if you're putting, lifting a moderately heavy weight is going to be a lot more painful if you don't have the proper biomechanics, the proper lifting. And that's kind of what a therapy team can help you with, help you identify and change. Another thing that's very common to use is assistive devices like braces, footwear, and walking aids. So I'll talk a little bit about these. So in braces, there's the most evidence in terms of research studies that show benefit. There's most evidence for bracing involving the knee and the thumb. There's a little bit of support for bracing of the ankle. When I say support, I mean demonstrated benefit through research studies. And I'll go back for a second. This this brace that's shown here is on the knee. It's called a unloader type brace. So this is for someone who might have arthritis on the inside of the knee, and the brace tries to realign the knee so that you're putting less pressure through where you have arthritis to provide pain relief. There's good evidence that this brace for people with that sort of arthritis does tend to help with pain and function. And this is a common brace people use for arthritis in the base of their thumb. All it really does is keep your thumb still so that when you're doing day-to-day activities and using your hand, your thumb's not moving as much, so it doesn't hurt as much. It's not as functional of a brace, but it does help with pain. Ankle braces, like I said, some studies have shown that they're helpful for people with arthritis, but the results are a little bit mixed. But if you do wear an ankle brace, what it typically does is hold your ankle to be straight at 90 degrees so that's not moving when you're walking. Again, it's not so much of a functional brace as it is just kind of stopping you from doing the movement that will make your ankle hurt. Orthotics can be an important part as well of managing arthritis in the knee and the hip and even in the low back. It's all about what we're talking about in terms of posture. You're kind of redistributing pressure so that you're putting weight and forces through the entire knee rather than focusing it on one area that has arthritis in it. Some people have leg length discrepancies, right? Maybe one leg is slightly shorter, slightly longer than the other. And having a specialist in the field kind of identify that and correct that might go a long way into putting less pressure on your joints so that when you have arthritis, it's not bothering you as much when you're walking. The picture there shows the example. if you tend to, have an inward tilt of your foot without orthotics, identifying that, putting in a proper orthotic can help realign your leg and allow you to do more with arthritis. Walking aids like canes or walkers, these reduce the load and pressure on your joints. I've shown a picture of someone with a cane here. What you tend to do with a cane is you hold it in the opposite side where you have the problem. So if you had arthritis in your right knee, you hold the cane in the left hand and you put the cane down when you're stepping with your right leg to basically to put some pressure off of the right leg. It's it works to just put less pressure on the area that you have arthritis and therefore reduce pain in that way. And it allows you to be more mobile if you have arthritis, which keeping moving does help with overall pain. In arthritis, you just have to make sure that you get the right size when you're using a walker or cane or anything like that. So talking with a therapist who knows what they're doing and can fit you for a proper walking device. Because if you're using the wrong size and obviously putting yourself in a bad biomechanical position, then it's just going to make things worse and not better. Okay, so in terms of medical intervention, there's a number of treatments that people use for arthritis. Again, none of these are really to fix arthritis. It's more to manage pain. Over-the-counter medications, acetaminophen, which is the main ingredient in Tylenol, very commonly used for pain control for arthritis. It has been shown to be beneficial. It's when used in the proper amounts, it's very safe medication. Another over-the-counter medication people use is non-steroidal anti-inflammatory drugs or NSAIDs. The common one for this is Advil, like ibuprofen. Ibuprofen helps with inflammation, can help with the swelling and pain, reduce pain. Ibuprofen does have a lot of side effects, can impact heart health, kidney health. So especially if you have any sort of other health conditions or concerns in that regard, it might not be the best to use, especially for the long term. There's also prescription medications that people use. You may have seen some of these or heard of some of these before. There's stronger anti-inflammatories that are not available over the counter, Celebrex being one of them. Meloxicam, people may have heard of. They also tend, just like ibuprofen or Advil, they tend to work very well for pain in arthritis. The concern obviously is with side effects and with kidney and cardiac health. Duloxetine or Cymbalta. This is a common medication used for arthritis, shown to be very beneficial. Physicians still aren't sure exactly why this works. It originally came out as an antidepressant, but it's found to have very good properties to help with pain control. We suspect it does that by modulating the nerves that send pain to your brain. So it's not fixing anything, it's just kind of turning down the pain receptors so that you don't feel the pain as much. Gabapentinoids, this is a class of medication that includes things like gabapentin or Lyrica, pregabalin's the other name for Lyrica that people may have heard of. Again, these medications originally actually came out as anti-seizure drugs. And then over time, people realized that they help quite a bit with pain as well, likely from dampening the nerve signals that transmit pain from the joint to your brain. And the last one being opioids, like morphine, hydromorphone, codeine. These are pain medications that are often used for arthritis. They do a great job for pain, but as you can imagine, all these things I talked about all have side effects. Right? Everyone knows the side effects of narcotics, and they're addictive, and people try to avoid them when they can. The antidepressants have side effects, like Cymbalta, usually, nausea, headache, stomach upset, that sort of thing. The gabapentinoids, like gabapentin or Lyrica, they can cause a lot of fatigue. So all these help for pain, but whenever you take any sort of medication, you're also dealing with side effects as well. So that's something to consider.
Are there a lot of long-term problems with taking those sorts of medications, like an NSAID or gabapentin? Are there long-term, because sometimes people, I mean, their pain doesn't go away,
Right.
and they are managing it with taking these medications, but how long can you take them before it's an issue with other health issues?
Yeah, NSAIDs for sure have a lot of long-term effects. Stomach ulcers, they'll cause. It's just a matter of time, basically. They'll cause a stomach ulcer. NSAIDs are associated with heart disease and kidney disease and high blood pressure. So very not ideal to be on them for long term. You know, especially unless you're, you know, very healthy, very young. I tend not to recommend them other than, you know, for a very short period of time. Cymbalta doesn't seem to have much in terms of long-term side effects other than the typical side effects you get with antidepressants. Like, you know, it does affect your mood, and it affects everyone a little bit differently. Some people find when they take antidepressants, they just feel kind of, you know, blah, right? They don't get high, they don't get too low, and that can be, you know, that can be not ideal for some people. The gabapentinoids and the opioids, they both do a great job for pain. They're both addictive in terms of your body gets used to them, and you need more and more and more through the years to have the same effect. So while they can do a great job for pain, you know, the longer you're on them, the more you're going to need. And, you know, they don't cause any, as far as we know, they're not causing any, you know, long-term heart disease or liver disease or anything, but they are addictive.
So if you were on those any of those medications, how often should you be monitored by your physician to
That's my
check?
question.
Right.
Yeah.
Yeah, good question. The NSAIDs I'd be most worried about, especially if you're at risk of having any sort of heart, you know, cardiac or kidney disease. You know, if I had someone who was, you know, maybe over 50 and on, you know, taking anti-inflammatories very frequently, I would probably want to do blood work at least a few times a year, you know, at minimum, and then, you know, tell them, you know, a number of things to watch for in terms of symptoms. Monitoring for these other drugs is not necessary. There's no specific time frame that I recommend. It depends on the person. And it also depends on the how much you're taking. You know, like if you're taking Tylenol 3 that has a little bit of codeine, that helps with your pain. You know, codeine is not a super strong narcotic. I wouldn't be as worried about that. If you're on high doses of morphine or something like that, then I'd want to, you know, keep a closer eye on someone and you know, make sure that they're still getting appropriate pain management and you know, not developing a dependence. So other medications, so topical medications. So topical medications like creams, they can be more valuable for people because they avoid a lot of the side effects you get with taking a pill, right? Because it's not going through your whole body, and in theory it's acting just locally at the spot. There's a lot of different topical options. A lot are available over the counter. The most evidence is for the anti-inflammatories, which is why I put 2 stars there. That's by far the most studied and by far the most effective in studies. The most common one you'll see over the counter is Voltaren. Right? It has diclofenac, which is an NSAID. People use it. Most people that use it will say it works a little bit, but it's not very strong, which is true. It's not overly strong. It's not as strong as taking a high dose pill, but it's something and really doesn't have any side effects other than, you know, some people react to what they put in the cream, might get an allergic reaction from that or a rash, but most people tolerate it very well. Capsaicin, topical capsaicin found in chili peppers, that's been studied and does show some evidence. It's in a lot of the over-the-counter products that you know, provide the warming sensation. Like certain like Bengay products have that. That's been shown to help a little bit. Menthol, which I've started there, also has some research behind it. It's the stuff that provides the cooling sensation. So, you know, like the hot, cold patches, it usually has a mixture of menthol and capsaicin in them. There's other products that people have used before, wintergreen oil, arnica, maybe people have heard of. Not a lot of evidence behind it, but not to say it doesn't work, it just hasn't been studied as much. Topical CBD getting more popular now. Research on topical CBD for arthritis is mixed, and I think a lot of that is people don't really know yet exactly what CBD, how much, all that's kind of still up in the air. But some people will try CBD, say it works great for them. Some people say it does nothing, and I think a lot of it has to do with we don't really know the right dose to recommend right now. Some mixed evidence for pain. Yeah, some mixed evidence for pain, not strong. And for arthritis specifically, the most commonly prescribed CBD is Nabilone, because it's in a pill form. It's been available for a while, and it's mostly beneficial for cancer patients and nausea. A little bit of benefit for pain. Most people say the side effects are worse than the benefit for pain. CBD oils, it's kind of the same thing with the topical. There's so many out there right now. I'm sure some formulation works. It's just not defined right now which one's great for arthritis, because there's, if anyone who's looked into it, there's a million different kinds of oils, a million different concentrations of CBD versus THC, and as of right now, there's not a great idea of, well, use this for arthritis, use this for nausea, that sort of thing. But that's probably coming down the line. So another topical therapy people use is compounded topical cream. So these are less common because they tend to be a bit more expensive. But these are made by a specialized pharmacy. There's one in town called the Bracebridge Compounding Pharmacy, and they're able to compound prescription medications in a cream at higher doses than you can get over the counter. So, for example, Voltaren, the diclofenac part of Voltaren is just over 1%, whereas the compounding pharmacy, might make diclofenac at 10% or 15%, 10 to 15 times stronger than you'd get over the counter. Yeah, these are all prescription. Yeah, these are all prescription, and similar to what I was just saying with the CBD field, there's so many different options, so many different percentages that there's not a lot of definition on, what works best for what condition and at what drugs and what percentage of drugs.
So if you were taking a 1% diclofenac solution and using it on your knees and it doesn't seem to be working anymore, I was told, you might need a higher dose, but how high a dose can you?
The highest that they'd usually make is 20%.
Okay.
Yeah.
I've been
And if
taking.
people have that, do you have any experience with people having a high percentage and it being more effective?
Yeah, and then I'll talk about that at the end too, because we're actually me and a group of researchers are hoping to actually study this specifically, and we're hoping to get funding for a study even starting next month to look at a certain combination there. But
If you're taking diclofenac, there's an experiment right now with the diclofenac cream, and I couldn't do the cream because I'm on the pills. They wouldn't allow me to do the study.
Where was the study?
I don't know. It's through Dr. O'Shaughnessy. He sent me there to a compound lab, I think out of Barrie.
Oh, okay.
And I don't always take diclofenac. I only take it when I absolutely have to because of the side effects. And I didn't realize some of the other medications contained it. So what level can you not take with the medication of cream?
Yeah, that's probably the study made some specific eligibility criteria because it's not defined. Yeah, in what it seems to be is, because I talked about all those bad side effects of anti-inflammatories, it seems like if you're using it topically, you don't need to worry about those side effects. So in theory, if you're taking it orally, you should still be able to use it as a cream. But like I said, likely in this study, if they excluded certain people, they likely just made their own decision that way. Other medical interventions, steroid injections, cortisone shots, another term for this. These, again, they don't fix anything, but it's kind of delivering an anti-inflammatory drug right into the joint. It's supposed to calm inflammation, reduce swelling. It can last anywhere from a few weeks to some people get several months benefit from it. There are risks to these sort of things, just like any pill has a side effect. Any intervention has a risk. You know, when you're using a needle, introducing it into a joint, there's always a chance it might cause an infection, right? Very rare to happen, but anytime you're puncturing into a wound, you could bring an infection into there. But this people do tend to get good benefit from it. Most people do, some people don't, and side effects are limited because again, it's working right at the joint rather than taking something by mouth that spreads all over your body. It stays localized to the spot. Some people may have heard of hyaluronic acid injections. These are very common in the knee. So this is when they take a substance that's normally found in joint fluid, like a lubricating fluid, and inject it into the knee, meant to help with lubrication, support, that sort of thing. This has good research behind it, especially for the knee. It does tend to be effective. The main problem with this is how expensive it is. Most drug plans and OHIP don't cover it, and it's usually I don't think it's several $100s, but it's definitely hundreds of dollars to have this done.
It can be upwards of $500 a shot for a knee, depending on what. If you get the generic, it's $250. If you get the needle disc, it's $500 a shot from an orthopedic surgeon that I just went to.
Right. So very expensive, and it's not permanent. You know, it lasts for 3 to 6 months, and that's about it. Another injection people may have heard of is PRP, or platelet-rich plasma injections. So these are very popular, especially because this is in the horse racing community. This is what they give to horses all the time. They take your own blood, spin it down, take the platelets from your blood, which include growth factors in there, and then inject it into your knee. In studies that have been done in humans, effectiveness is mixed. You know, some people find good response, some people don't. Again, this is another extremely expensive injection, and especially since the evidence behind it is not fantastic, a lot of people don't get this done. A few will, but it's mixed if it works or not. So lastly, surgical options. So surgery is really the only thing that can take away arthritis because they're cutting out the diseased bone and replacing it with metal. That's basically how most surgeries work, except for arthroscopy. So arthroscopy is minimally invasive surgery with cameras. And typically when this surgery is happening for arthritis, they're just removing debris. So maybe there's some loose cartilage, scar tissue. They try to kind of clean up the joint a little bit. Sometimes effective, not a long-term solution. And especially you can imagine if you're removing cartilage or smoothing things out, eventually it's going to get worse because you've just taken away more of the cartilage, and that's what's protecting your knee. Arthroscopy is usually for younger people who maybe had some sort of injury, maybe had a tear in their cartilage. They're trying to fix that, knowing that they're likely going to develop arthritis worse later in life. But this is the best option that we have at the time. Osteotomies are also sometimes used, again, mostly in younger people, trying to avoid a replacement because replacements only last for so long. There's an example of an osteotomy here. So you can see on the knee on the left, there's arthritis forming on the inside of the knee so that you're kind of having bone-on-bone destruction there. So instead of replacing the knee itself, they break the lower bone, realign things to try to realign the joint so that the joint function is more smooth and works better. This again, this is done for people who have maybe arthritis only in one part of the knee or are younger and are worried that if they get a replacement too early, they're going to have to get multiple more replacements later in life and have complications from that. Joint replacements are the most common. So this is when they replace the damaged joint just with artificial prosthesis like a metal. So it's ideal for severe arthritis, especially when it's in multiple joints. You can see the pictures there, the before and after. They've taken away the diseased bone and they've kind of replaced it with metal. Replacement parts, typically, the current ones typically wear out after 15 to 20 years, which is a long time. But doing a revision surgery, like, replacing a joint is a much more complicated procedure and has a lot more chance of complications and poor outcomes. So if it has to happen once, you're going to expect less function out of your knee. But especially if you're thinking of multiple times, you're getting to a point where you might be talking about an unusable joint. So ideally surgeons try to delay the replacements until they think, in 20 years from now, you're not going to be running anyway, so you don't need a really functional knee. This is what a hip replacement looks like. So you can see they've taken out the ball and the socket. They replaced the socket with the prosthesis, and they replaced the ball with a metal ball that go with a shaft that goes down into the femur. Shoulder replacements are sometimes done, not quite as good outcomes as knees or hips, because the shoulder is a more complicated joint, right? It has much more range of motion, and there's a lot more tiny muscles and ligaments involved. But what they'll do in the shoulder is very similar to a hip, replacing the ball, replacing the socket, and primarily for pain control. The shoulder replacements are great for pain control, not as good for function compared to knees and hips. So usually when you're getting when you're talking about a shoulder replacement, you're not really talking about having a really great functioning shoulder after. Not that it's going to be useless, but with a hip or a knee, you can expect to going back to a lot of activities. With a shoulder, that expectation might be a little bit more limited.
I know this is going to sound like a dumb question, but I'm going to ask the question. So those parts are metal. So if you have a metal knee, how does minus 40 weather affect that or the hip?
Not having any metal in my body, it's hard. I haven't really heard people complain about the weather affecting their prosthesis. Weather certainly affects arthritis in terms of, depending on the air pressure, it can affect inflammation. So, lower pressure, you tend to get more inflammation in your joint, it can hurt more. It should be less when you have a prosthesis because there should be less inflammation, I would think. But yeah, I haven't really, no one's told me that they've been bothered by that. Okay. So in terms of replacements, yeah, the hip is by far the most successful and the most durable replacement. It's a very simple joint, especially compared to the shoulder. As I've said here, most last 15, 20 years, very high satisfaction rate post-hip replacements, and you tend to have a very fast recovery. In fact, some people will even say, I walked 2 days later, I walked out of the hospital in better shape than I was before I went in. Even just 2 days, they're recovered before, better than what they were before. Knee replacements are also highly effective, a little bit less in terms of the satisfaction from knees, but still very high satisfaction. 80 to 85% of people are satisfied after their knee replacement. And again, most last 15 to 20 years, similar to a hip. We talked about the osteotomies before. Some, depending on what kind of arthritis you have and what your surgeon thinks, they sometimes will talk about doing a partial knee replacement where they only replace part of the knee. That's kind of person dependent and surgeon dependent.
I've heard of people doing both their knees at the same time now. How common is that? It's not very common, but some people have done that.
Most of the people that go for replacements in this area go to Aurelia or Barrie. I don't know anyone that's had both done at the same time. In theory you can, but you're playing with fire a little bit. If the recovery is not as smooth as you'd like, then you basically become non-functional. Where most people can function for a period of time, with recovering one leg. Recovering both, you might be in a situation where you need a wheelchair to get around, or
What happens if you have both on the same leg?
Hip and knee.
Hip and knee.
Oh, wow.
Yeah, a lot of people get both done on the same leg. Yeah, not at the same time. Not at the same time. Sorry, yeah, different times. But But certainly, like a lot of people, it's not very uncommon at all for someone to get their knee done, recover, 6 months later get their hip.
What would you suggest to be done first, a hip or a knee? Or
Well, it depends on the person. Yeah, it depends on the person. It depends on where your pain is. Because a lot of times people will, like let's say if you get your knee done and all of a sudden you're walking a bit better, then maybe your hip's not so sore, you don't need it. So it really depends on where your pain is, because everyone's a little bit different. Like I've shown a lot of x-rays of people's knees. X-rays tell us a little bit about the story, but sometimes people have, bone on bone arthritis and very little pain. We can't really explain why, but some people have, maybe more mild arthritis, but have severe pain. There's a lot of things we don't understand about the body and joints and everything, but basically what I recommend is start with what joint is bugging you the most, or maybe what joint is most misaligned, and then figure out what you need to do after that. This is a shoulder replacement. I just show these pictures because there's actually 2 different types of shoulder replacements. The one on the left is like a typical shoulder replacement that reestablishes normal anatomy. On the right side is what we call a reverse replacement, where they actually put the ball into the socket and just have the shoulder hanging free, supported by muscles there. It depends on the specific form of arthritis you have. Depends on things like your rotator cuff health, and it has implications. Usually, the reverse shoulder replacement is less functional. So it depends what you need the replacement for and what you're hoping to get from the surgery. Shoulders, like I mentioned before, good outcomes for pain relief typically, not as great for hip and knee in terms of function, and much longer rehabilitation, much more complicated joint. There is other surgical options for other smaller joints like ankle and wrist, much less predictable outcomes. So typically, if you're getting to this point, it's because you have severe pain, it's not responding to anything else, and you're not expecting much in terms of function, you just want pain relief. Now, this kind of technology changes all the time. Obviously, people are studying this, trying to find a better prosthesis, but at this point, these smaller joints, not as predictable in terms of outcomes. Okay, so lastly, I mentioned this a little bit earlier before. Myself and a group of researchers do have potentially, depending on if it gets funded, an upcoming study about topical pain medications for treatment of osteoarthritis. In our specific compound, there's going to be diclofenac, that anti-inflammatory that's in Voltaren. It's at 10% instead of the 1% that's in Voltaren. It also has lidocaine, which is a anesthetic, like it's a freezing agent you use before you get stitches or something like that. And amitriptyline, which is an antidepressant, kind of like, somewhat similar to Cymbalta that people use for pain control, all given topically. So we're comparing this to Voltaren, because this kind of compounded cream is expensive. It's probably about $90 for 2 to 3 months supply. So the goal of the study would be, if you're in this study, obviously you get the cream for free. You don't know which cream you're getting, but you get the cream for free. And then we can help kind of figure out, is it worth the money to spend for these, more expensive creams? Do they provide a lot more benefit than Voltaren? Or if it's the same as Voltaren, then you might as well just buy the over-the-counter cheaper stuff. Anyway, if you're interested in learning more about it or want to be contacted if and when it starts, if you use your phone on that QR code, you can put your name and information into a Google document that one of the researchers will contact you when it's time.
Does it matter which joint we're talking?
Doesn't matter which joint, yeah. Doesn't matter which joint. And part of the study as well is, I mentioned and we talked about the side effects that you get with oral medications. So far, what the research has shown is topical medications don't seem to have those same side effects. But that's one of the things we monitor in the study. Like we check your kidney function, check liver, everything like that, just to confirm that the topical treatments are very safe to use and see if they're effective. So anyway, if you're interested.
How long is the study for? 6 months, a year, 3 months?
No, it's now you're testing me. I think it's 12 weeks. 12 weeks, yeah. Yeah, so how it would work is you don't know what you're getting, but for half the time you get one cream, and then half the time you get the other. And then during that time, you say, which one worked better, which one didn't work, that sort of thing.
Be using a placebo group?
So the placebo is the Voltaren. That's what we're comparing it to. Is
Would be off any other medications you have.
no, you can stay with everything else. Stay with everything else. Yeah. We decided to make the placebo Voltaren because one of the main things, like I said, that we wanted to know was, is it worth buying the more expensive stuff versus getting the over-the-counter, what's available over-the-counter for relatively less money.
Question, Dr. Karen Baker, our physiatrist, mentioned in her session that it's evidence-based that turmeric is an anti-inflammatory and can be used. So you haven't mentioned that at all in terms of non-surgical treatment.
Right. Some people find it is evidence-based. There's not a ton of great evidence behind it, but some people find good response with turmeric. Glucosamine is another one I didn't mention. Kind of similar to turmeric in terms of there is some limited benefit to it demonstrated in research that some people find relief with. So both of those kind of more natural substances can be beneficial. Not as clear in terms of side effects or long-term effects with either of those, just because they haven't been studied for as long as some of the more prescription medications.
Mm-hmm.
I was told to be careful of turmeric because of the anticoagulating properties of it, that you have to be careful of your dosage of it.
Yeah, and that's similar to other anti-inflammatories. They can thin your blood. They can cause all sorts of problems. I mean, they work really well for pain, but unfortunately, they cause so many side effects too.
So when you're saying it thins the blood, it's making the platelets less sticky? Is that?
Yes. Yeah.
I've heard that if you get shot in your hip, that and you're leading towards an operation to replace it, that shot has to be out of your system completely before they'll operate on you.
So correct. Yeah. Most surgeons want at least 3 months after you've had a steroid injection. Some want longer. Depends on the surgeon. What they're worried about is risk of infection in surgery because they really don't want an infection in the joint, especially when they put a metal piece in there. Your body, wherever you have blood flow, your body can fight something. Metal doesn't have any blood flow. So if they did this surgery and, an infection got onto the prosthesis, there's no way to treat it other than having surgery again, washing it out, taking it. It's a big problem, and it will lead to very bad outcomes. So most surgeons, though the risk is low, they want the risk to be very, very low. And if you ever had like a needle into a joint, they just want a long enough washout period that they're very confident that there's nothing in there that could cause an infection. So that's the reasoning behind it. But if you are on a wait list for surgery and you're not exactly sure when it's going to happen, I usually recommend people don't get their cortisone shot just in case they get called, we can get you in next month. You'd have to cancel it if you just had a cortisone injection.
Oh, maybe that's why they after you have like hip surgery, you're not to have any like oral surgery or anything up to 2 years because it can affect the bone. I didn't realize that till now. They don't want you to get any infection.
Again, that's somewhat surgeon dependent in terms of what they'll recommend. But that is the concern is that, if you have a dental procedure, usually when you have a dental procedure, you get some bacteria that goes into your blood because the dentist is, causing some bleeding and everything, and your body can normally handle that. But if you have something that's foreign that it can, that if the bacteria gets lucky enough to attach to that and your body can't kill it, then you could end up with a problem.
Okay, another dumb question. So then after the surgery, why don't they just give you a 2-week course of antibiotics?
They do give you antibiotics during surgery. Yeah. After they typically don't. Yeah.
Some of the dentists, though, it used to be that every time you went in to have a procedure, my dad had all his joints replaced, and every time he went in to just have his teeth cleaned, he had to be on antibiotics. But now a lot of dentists are saying it's only after 2 years that they will say that you don't have to do that each time you come for an appointment. It varies. Some dentists are...
Right. It does vary. A lot of it is because people don't know for sure exactly what the best is, and most people err on the side of caution. I mean, realistically, I mean, a lot of surgeons won't mind if you have a dental procedure after a hip replacement for anything at all, and almost always it's fine. But it's just the one time it's not can cause a big problem.
So if you have any surgery for, like, say, a 2-year period of any kind, like any surgery after you've had a replacement, you have to be careful, it can still infect, correct? That's what you're saying?
Yeah, very low risk. Very low. I mean, like if you had your appendix out or something.
Like after this or something.
Yeah. I mean, in theory, it could happen. Very, very low chance of that typically. Like the biggest risk is the surgery itself, like when things are opened up and you're putting it in. Like that time is the biggest risk. Everything else is almost more theoretical.
Well, thank you very much.
Okay.
Yeah, thanks everyone.